Hello again, everyone. In this segment, we're going to look at some of the ethical issues in selection of control groups. And we're going to look at two examples. First of all, we're going to look at placebos as the control group, and then we're going to look at issues in the use of standard of care as the control group. So let's start with the issue of placebos. The question here is, when should a new drug be tested against a placebo or an inert control rather than against another effective agent that would be an active control? Now, Dr. Hill addressed this a number of years ago when he asked, is it ethical to use a placebo? He wrote, the answer to this question will depend, I suggest, upon whether there is already available an orthodox treatment of proved or accepted value. If there is such an orthodox treatment, the question will hardly arise, for the doctor will wish to know whether a new treatment is more or less effective than the old, not that it is more effective than nothing. And indeed, the public has picked up on this ambiguity and seems to share this view. Here's a cartoon from the New Yorker, tombstone of a member of the placebo group, and it raises the question of why would we ever assign somebody to a placebo therapy? But in fact, in clinical research, there are a number of reasons why we do use placebos. So first of all, it's necessary for drug approval. In the United States, the Food and Drug Administration generally requires placebo controls as a prerequisite to drug approval and has rejected applications based upon comparisons to active controls. Second, it's also a statistical benchmark. Placebo-controlled trials provide an unambiguous answer to the question, does the drug work? But as Dr. Hill pointed out, this may not be the most important clinical question. Third are issues of statistical efficiency. Since the differences in effect between new drug and placebo are greater than between new drug and competitor drug, one needs a smaller number of patients to show a statistically significant difference. And finally, the use of placebos allows us to avoid difficult comparisons. Comparisons to a placebo are straightforward, but comparisons to other drugs involve making trade-offs. To give you an example of that, imagine you're doing a study on a new hypothetical ACE inhibitor that we will call Better ACE. So what study design should be used? An active control or a placebo? Well, suppose you choose an active control, let's say the drug captopril. And hypothetically, let's just say that with captopril, you find an 8-torr reduction in systolic blood pressure, but with Better ACE, you find a 4-torr reduction in blood pressure. But Better ACE has far fewer side effects. So what do you conclude? I mean, it's not really clear what you would do with this information. And the placebo-controlled trial allows you to answer an unambiguous question, does this drug work? Now, the problems go even further than this. This is an example from a paper by Robert Temple and Susan Ellenberg. And when I first saw this example, I frankly was kind of stunned. This is a series of 6 studies that you see over on the left there that were comparing a new antidepressant, nomifensine, with an established antidepressant, imipramine. And what they did is they looked how these two drugs performed in comparison to baseline as measured with the Hamilton Depression Score. So if we look at the 6 studies, in the first one, as you can see, it looks like both of the drugs perform better, that is, reduce the depression score significantly from baseline. Similarly, in the second trial, same in the third, same here, and same in the 6th as well. So now, if you were to just sort of eyeball these data, it would look pretty clear that both of these drugs were effective treatments for depression and that they were roughly equivalently effective. But it turns out that in all 6 of these studies, a placebo arm was included. And that's where the surprising part comes in. Because here we see the depression scores that were associated with use of the placebo. So here in the first study, we see that neither drug really seems to be much different from placebo. Same in the second, same in the third. Only in the 4th study do the drugs appear to perform better than placebo. Not in the 5th, not in the 6th. So what is going on here? I mean, here we've got certainly imipramine, which is considered to be a standard antidepressant. Why is it that in this example, so often the drug shows up as no better than placebo? Now, it turns out that this is a common problem with active controlled trials. Certainly there are some situations where there is external evidence of efficacy that is very reliable. Certain types of cancers, infectious diseases, some cardiovascular conditions, for example. But there's many situations where drugs that we commonly consider to be effective show inconsistent results when compared to placebo. These include drugs like antidepressants, analgesics, anxiolytics, antihypertensives, asthma medications. And as you know, these are some of the most commonly prescribed drugs in the world. So it's a very important problem. Now, why does this happen? Why do these drugs show up as not being better? And there's not great answers to this. I mean, it may be that there's a variable response among the study populations. It may be that the group you're studying had insufficient adherence to the therapy or was using additional medications. There may be study samples that improve spontaneously, leaving no room for drug-induced improvement. Perhaps you happened to be unlucky and chose a study sample that was unresponsive to the drug, or there might be some other reason that we haven't even identified yet. But the point is that in all of these cases, the problem is not identifiable a priori by examining the study. It is recognized only by the observed failure of the trial to distinguish the drug and placebo treatments. So this is just a really important reason why sometimes we do need to do placebo studies. In fact, oftentimes need to do placebo studies in order to establish the validity of the study. So given that, when are placebo-controlled trials ethical? There are constraints on them. So first of all, they're going to be ethical if there are no effective treatments known, or if the placebo design is considered necessary to determine efficacy, as in those antidepressant trials. Secondly, the placebo-controlled trial is only ethical if it will not expose patients to increased mortality or serious morbidity. And third, we always want these studies to be time-limited. So it has to be a situation where a time-limited trial will provide you with the evidence that you need. Now, as we talked about earlier, a couple of things then to focus on are to reduce the risks of the trial to the greatest extent possible, compatible with a valid study design, and to assure that the subjects provide high-quality informed consent that is fully informed and voluntary. So how might we apply this, for example, to a placebo-controlled trial of a new antidepressant? So first of all, we're going to want to reduce the risks. We're going to do that by monitoring all of the subjects' level of depression carefully. We're going to provide rescue treatment if potentially harmful depression is detected. We're going to monitor for serious adverse events, such as in this case suicide, for example, and then limit the duration of the study. And then secondly, we're going to pay close attention to informed consent, make sure that the subjects understand the trial design, including the possibility that they may receive placebo, and understand that they always have the alternative of not enrolling in the trial and receiving standard therapy for depression. Okay, second, let's look at issues that arise with the concept of standard of care as the control arm of a study. So to start us off, there's really two ambiguous meanings of the term standard of care. So the first meaning is whatever is best evidence-based practice. The second meaning is whatever care is available and usually provided in the community where you're doing the research. Now these two definitions sometimes do not coincide, particularly when we're doing research in developing countries. And one of the best known examples of this were the studies that were done to prevent transmission of the HIV virus from pregnant women to newborns. So the question here was whether zidovudine is effective at reducing maternal transmission of HIV to newborn infants. And so there was a well-known study done in 1994 that used a protocol called the ACTG 076 regimen. It was done in the United States and France, and it tested this regimen in a randomized, placebo-controlled trial. It involved an intensive regimen of both oral and IV zidovudine to both the mother and the baby after birth, and it was very successful. There was a 66% reduction in vertical transmission of HIV. So at this point, this became the standard of care in terms of best evidence. And for further research that would be done in the United States, for example, it would no longer be permissible to randomize women in these kinds of studies into a placebo group because, as we discussed, it would expose them to the risk of increased morbidity or increased mortality or serious morbidity. So then the question comes up, well, what about if we want to look at how to reduce vertical transmission of HIV in Africa? What should be the control arm? Should it be the standard of care as defined in the United States or France? And the problem with that is that the 076 regimen would be very difficult to implement in Africa. First of all, there's the cost of the drug, although that might be provided by the drug company at no cost. But still, there's the cost of testing pregnant women to know who to include in the trial, who to treat, high frequency of home births, which makes this kind of research difficult to do, late prenatal care, which could interfere with the women being able to take the medication, high prevalence of breastfeeding, which includes the complication that maybe there'd be another way that the infants could become infected. And so for all of these reasons, there was controversy about which control arm to implement. So the question would be, if you want to study, say, more feasible regimens of treatment to decrease vertical transmission in Africa, such as shorter courses of treatment, oral administration, this sort of thing, what should the new interventions be compared against? Should you compare them against the 076 regimen, which is the sort of understanding of standard of care number one, best evidence-based practice, or do you want to compare them against placebo, which is the care available and usually provided, which in this case would be nothing? So this raises the question of whether there is an international standard for ethics. In other words, a standard that should be applied globally. Now in 1994, the World Health Organization, in talking about these trials in Africa, stated that placebo-controlled trials offer the best option for a rapid and scientifically valid assessment of alternative antiretroviral drug regimens to prevent the perinatal transmission of HIV. In other words, the view here was that the relevant question is whether the new treatment is better than usually available care, which in this case was nothing, not whether it is better than a standard which is unavailable to the population under study. Now, in the years since then, opinion has changed. And so today, the prevailing view is that there is a global standard and that these international standards should govern. So as the CIOMS guidelines state, the ethical standards applied should be no less exacting than they would be in the case of research carried out in the sponsoring country. So it's important to know that if you're, let's say, an investigator in the United States who wants to do trials in the developing world, whatever trial design you come up with needs to be ethically acceptable by standards in the United States if it's going to be acceptable to perform in the developing world. So, in conclusion, what we've covered here is that placebo-controlled trials may be ethical when they are necessary for scientific value and validity and when they do not expose subjects to increased mortality or serious morbidity. Secondly, for research in the developing world, control arms that do not conform with best evidence-based practice are generally considered unethical, but may potentially, in rare cases, be justified where they are necessary for both scientific validity and social value. Thank you for your attention.